Today in our rounds discussion, we had Dr. Anderson and special guest with Dr. Clark, who's a radiation oncologist in the area. And today we got to speak a little bit about stereotactic radiosurgery. So give us a little bit of a background of what I guess we were talking about today.
Technology has actually been around for quite some time. It seems really new and novel, but honestly, it's been around a while, and it's gotten refined and improved over the years. Stereotactic radiosurgery, I think, tells us exactly what it is, right? So it's radiation based, and it's very focal. It's like surgery. Surgery is a very specific and a very targeted approach to treating pathology. And radiation oncology is a field that's kind of blown up out of that technology coming into existence. And so when we can target radiation to a very focal area, then we can treat the bad things and leave the good things. And instead of just radiating a whole area like we commonly think of, the entire chest, the entire brain, all of those things, that does have an impact, but it is impacting all of the tissues, and we're hoping that the bad ones are dying more than the good ones, but you almost always lose some good ones. And so the ability to focus in and only hit the areas that we want to and leave the other ones alone allows us to have much better outcomes, less side effects and things like that. And so with surgical precision, to be able to go in and treat these pathologies with radiation, which is non-invasive, right? Doesn't require open resection surgeries, certainly not removing parts of the skull or anything like that. We can do this in an outpatient center, 1 to 5 fractions typically, and we can treat what we want and leave the good stuff alone. And it's really changed how we do things, coupled with oncology and the progression in chemotherapy agents and immunotherapy and all of those things has allowed us to be able to treat people with cancer much more efficiently, more effectively, and with much less side effects. I think that's the main thing. It used to be we always would think, oh, chemotherapy, you're sick and horribly ill. And sometimes that still occurs, but not anywhere like it used to. And so people are actually still able to be relatively healthy as they go through these treatments, which is fantastic.
Yeah, so as a patient, my first thought when you hear the word cancer, it's something that's intimidating and it's scary, and you always go to the worst case scenario, but this sounds to be a bit less than that. So from a patient's perspective, I guess, what are the important things to know about this stereotactic radiosurgery?
I think when they come in the office and they know they've been told they have a brain tumor, like I can't, there are very few things that would be more scary or intimidating than that.
Yeah.
And so to be able to tell them like, hey, we can actually treat this without surgery, right? We're not going to be opening your head up and going into the brain. We're going to treat this with radiation. I think, and we kind of explain the processes, the side effects, and different things that can occur. But honestly, they're pretty minimal. They're almost never really serious. They're relatively mild if they do occur. And so it gives them one less thing to think about. They're already dealing with a lot. Most of the time, this is metastatic from somewhere else. So they already have to accept the fact that they have metastatic breast cancer or whatever the source might be. And this gives them one thing that they don't have to maybe be quite so nervous about, quite so anxious about. And so I think, again, it makes their cancer experience a lot more tolerable and less daunting than it would otherwise be.
And our other guest that we had today was Dr. Clark, a radiation oncologist here in the area. How is it that you two really coordinate and work together?
I'm trying to honestly remember how I even got connected with him in the first place. So this partnership does exist. And I think if you go to all of the large cancer centers in the country, this is exactly how it works. If you go to MD Anderson or Cornell or any of the places that are well known for treating cancer, you're always going to have neurosurgeons and oncologists and radiation oncologists working together to treat CNS tumors. And I don't recall exactly how we got on each other's radar, but we did. We met and connected, and I said, hey, this is something that I do, something that I offer. And he said that would be amazing and fantastic because that's what he experienced during his training when he was in academics. And he recognizes the value of having a couple of perspectives for these patients. And so my goal or my job really is to very, very much focus in on the tumor, the location of the tumor, protecting the structures around it that can cause side effects. And his job is primarily to treat with the dosages, right? And to actually run the radiation treatment. And then there's a physicist that's involved that does all sorts of calculations, again, all about safety. And so these are extremely safe. We're not just kind of sliding someone in and zapping it, you know. There's a lot of work. Most of the work that occurs is behind the scenes. So he sends me a text message and says, hey, I saw this patient. They've been simmed, right? I've got the program uploaded. And then I stop by whenever I have free time, usually at the end of the day or early in the morning. And I hop onto the computer. I go through and make my adjustments and changes. We kind of talk about things. We talk about, you know, maybe we should expand it here, or that's getting a little bit close to that there. And so we kind of together finalize that plan, and then we save it, and then it gets calculated with the physicist and everything, and we execute the treatment. The day of treatment, there's really nothing to it. Then we're just executing the plan that we've already spent a lot of time planning for. Yeah. And so it's nice because we get to basically do all of that work, and then we know the treatment's going to go perfect. We know it's going to go well because the machines are amazing and they execute what we tell them to execute. And so the treatment is quick. The patient comes in, they get treated. It takes 5, 10, 15 minutes or so per fraction. They're out the door again. And really the collaboration, I couldn't do it without them for sure. Yeah. They could do it without me. They don't have to have me there, providing my neurosurgical supervision, but I think they would tell you that it gives them a lot more confidence, and they feel a lot better knowing that I'm there to help them. So it really is a great collaboration that exists, and the winner is the patient. The patient gets the best outcome that they could possibly get, because I see something that they don't really think about, and not as a neurosurgeon. And then certainly they're going to be way more in tune with the radiation aspect of things, and how to shield and protect and do all the things that they do. And my view is much more simple. I want that thing gone and stuff. And so I think when you have both of those things in place, then the patient really gets the best outcome, which is why we're all here. Yeah.
And I think that's a perfect way to put it, is you've got obviously the knowledge and the experience with the anatomy and the neuroanatomy and the cranial surgery lens that you can lean on. And then these guys are very well experienced with the oncology and the radiation and the treatment protocol. So that seems like a great way to team up. Talk to me. I was a little bit surprised about this myself, actually, was the way that the patient goes through the experience of being immobilized, I guess, for the treatment. Because where you're talking about being so precise and so focused, it sounds critical that the patient does not move during these procedures. They're not long, but they need to be held still. Mm-hmm. So previously, you guys were actually surgically fixating a plate to the skull, but now it sounds like you've gone away from that a little bit. What is that like now?
Yeah, so historically, Lexel frame, Lexel was basically the inventor for a lot of these early technologies. And so we would put 4 cranial pins into the head, and that had a frame that had little windows. And basically when we would get imaging based on where the beads were or where things lined up in these windows, you could algorithmically calculate exactly where everything was in spatial orientation. And so that's what we had to do. And obviously with it screwed into the skull, it didn't go anywhere, right? So your body could move around, but your head was not moving in relationship to that frame. That frame would be locked into the machine, and then we would deliver the treatment. It is still the most precise way, but obviously a lot more involved and a lot more invasive than what we do, and it's not necessary in most of our treatments anymore. And so the mask technology really does kind of vacuum seal this mask around the patient. The add of the bite block, further secures that, so there's no motion. And certainly we don't want people moving, right? If we're shooting a small target that's 6 millimeters and they're moving 2 millimeters one way or the other, that goes from us, covering all of the tumor to not, and covering very minimal normal brain to covering normal brain. Yeah. And so once they're all created and made, that mask is now theirs and it fits them. And when every time they come in, they get placed in it. But we don't even just trust just the mask. We then do a cone beam CT scan on the machine. And that machine, that CT scan then overlaps and merges with the MRI we did our planning on. And we line up to make sure that the CT and the MRI are merged perfectly. Because again, a little bit of deviation can result in a bad outcome. And so we do that at the beginning of the case. And oftentimes even at the end, they get another CT scan to show that there was no movement during that procedure. So this really all does come down to the millimeters, on what we're treating. So it to watch it or to kind of discuss all the pieces and parts, it seems like, man, there's a lot of things that go into this, and there are, but it's a very well-established process. So it goes very quickly. The patient doesn't really need to worry about much of anything. They're just said, okay, do this, and we're done.
Yeah.
And so again, we spent a lot of time behind the scenes. It would seem, I think, even from the patient's perspective, it's like, really, that was it? Like, man, that was simple. But there's a lot going on behind the scenes from all of us, and I love it because I get to collaborate with them. I get to talk to them, and it gives me a chance to feel like we're from different specialties, but we're sitting down together, to treat a problem, and we don't get to do that a lot. Very often our treatments are very fractionated. So I love being able to sit down with a team and say, how are we going to treat this tumor? And I think, and it makes for better outcomes. I think if we could do that on everything, it would be better. We just don't usually have that opportunity.
Well, that's great. Always impressed and amazed by your experience and the service you guys provide to the community. Grateful to learn more about that today, and we appreciate you sharing.
Absolutely. It's my pleasure. I love it.